welcome to MOH Sigvaris. Good morning, good afternoon, good evening, wherever you are in the world watching this. Welcome to our subject today. Some of you have seen me before. My name is Katie Stevens. I'm the clinical nurse advisor for Sigvaris in the UK, and I cover the south of England. My background is a lower limb specialist nurse, community nursing, tissue viability, but I've been with Sigvaris for the last year, and my passion are legs and about how we can change our practice to improve patient outcomes. So that's what brings us to our topic today, chronic edema and the healthcare burden, and why self-care really matters. We know that chronic edema is a huge problem and it really affects our patients and our services. So hopefully we're going to provide you with some education and a patient viewpoint about how it really affects our patients. We have a panel, an expert panel today. We've got Professor Rabe, which I'm honoured to have you on here today. Professor Rabe, thank you. You need no introductions. Everyone is very, very familiar with the extensive work that you've done around legs, and I'm really honoured for you to be here. So thank you for joining us. We then have Claire Mitchell, who's a senior community nurse. So she's going to talk to us from a real world position of what it's like working as a nurse and trying to manage chronic edema and how we can support our patients with chronic edema. And then we're going to hear Julia Richardson's story, who is a patient who's had experience of chronic edema, lymphedema, and she's going to tell us a very moving story about her experience for the last few years with chronic edema. So welcome to all of you. So if anyone's got any questions, please pop them in the chat or ask us afterwards. This will be recorded so it can be seen at another time, and any questions we can't answer today, we will get back to you and put them on the platform, and you can see this on any of our social media channels. So first of all, I think we can go over to you, Professor Rabe, and you're going to discuss some of the anatomy and physiology of chronic edema and talk about supportive self-care, how that can help patients, and what happens if we don't do anything at all, which is currently happening. So Professor Rabe, over to you, please.
Thank you very much. I hope I can get my slides. However,
I can share your slides. If not, just let me know.
Now that would be nice. Okay, so that is okay. Perfect. Can you see the slides now? Yeah, you can.
Yes, thank you.
So that's my conflicts of interest. Yeah. So chronic edema. Sorry, the first.
Okay, we'll start with the first. Thank you.
Thank you very much. So it's so nice to be here, and thank you very much for this kind invitation to speak about chronic edema as a burden on the healthcare system. And it's not really a question mark, as you will see, because chronic edema is really a burden on the healthcare system. Next slide, please. These are my conflicts of interest. And the next slide, please. So Christine Moffat said that chronic edema is a broad term and used to describe edema which has been present for more than 3 months. So that's called chronic and involves one of the more of the following areas. We know that the limbs are the most important manifestation point of edema, but also the upper body and buttocks, abdomen, genital edema, head and neck or face can be involved in edema formation. Next slide, please. So chronic edema includes lymphedema and venous edema. These are the most important ones. And chronic swelling due to immobility in obese patients, for instance, related to cancer, and chronic swelling associated with lipedema, for instance, or related to obesity, which is also a very important point, which you will see, and chronic swelling associated with rare vascular malformations like Klippich-Trenaunay syndrome. Next slide, please. So in the past, we thought that the filtrated volume in the capillaries will be reabsorbed in the venous side of the capillaries in the venules. But we learned in the latest years that is not true. And we have to think about that the reabsorption of fluid from the tissue does not play an important role in the normal situation when you are sitting, when you are standing, when you're going around. That might be a point when you are lying in the night, but not during daytime and not in the normal situation. So we have to learn that almost all the filtrated fluid is transported, absorbed, and transported through the circulation back by the lymphatics. So as you can see, any kind of edema in that way is involved or involves the lymphatic flow and the lymphatic transportation. It's not all what we call lymphedema, but lymphatic function plays a very important role. Next, please. So edema arises when the capillary filtration exceeds the lymphatic drainage. You have to keep in mind that the lymphatic drainage has a big, let's say, reserve function. You can transport 10, 20 times the volume you usually do in case when edema formation is going on. But if the capillary filtration exceeds the lymphatic drainage, then you will have edema. And that is true for all kinds of edema. You may have a normal filtration, which is just normal, no venous edema or things like that. But you may have a reduced lymphatic transport capacity, which is the case in primary lymphedema, for instance, or in secondary lymphedema also. So you may have a normal filtration, but your lymphatics are not in order, so you will have edema. The other way around, you may have an increased filtration, and your lymphatics work very well, but the increased filtration exceeds the lymphatic transport capacity. And in this case again, you will have edema. And that is the case, for instance, in venous edema, cardiac edema, and whatsoever. The next slide, please. If you look to the prevalence of chronic edema in acute hospital inpatients, which was done by the Limprint study, and we will come back to Limprint several times because it's a big network of studies which has been done on chronic edema. So as you can see, the location of chronic edema in hospital inpatients is 96% in the lower limbs.
Everything's stuck from my end.
Sorry? Can you hear me?
I think the technical team might have a look at that, Professor Rabe. I can hear you fine. If you keep going, that would be great. Thank you.
So again, the prevalence, if we look to the prevalence of chronic edema in acute hospital inpatients, the location is 96% in the lower limbs. So it's the majority of patients. And then you have some in the upper limbs, genital edema and so on. And the overall prevalence in this age group of the mean age of 73 years in the hospital inpatients is 38%. So 38% of those patients have chronic edema when they are in the hospital. And the risk factors are, of course, age, it's morbid obesity, which is very important. Of course, it's heart failure, and also chair bowel immobility and neurological deficiency are risk factors. There are some complications. If you look, for instance, in chronic edema and wounds, edema is present in 24%. So wound patients, one quarter of the patients have chronic edema. In chronic edema alone, it's 14.1, cellulitis. If you have patients with chronic edema and wounds, 24% develop a cellulitis. In chronic edema patients alone, it's only 14%, but it's 14%. And we will come back to that complication later on. Next slide. So if you look to older populations receiving community care, so not in hospital patients, they looked for those, in this study, they looked for those patients, and the mean age was even higher. It was 80 years, 80.3 years. And you can see again, 38% 0.1% is the prevalence of chronic edema in those patients, and 85.4% have bilateral edema if they have chronic edema. And the main risk factors in this age group is chronic heart failure and also using mobility aids. So immobile patients are prone to develop chronic edema. Next slide, please. If you look to the bariatric patients, and we saw already earlier on that obesity is a risk factor for chronic edema. And you see in the bariatric patients in this study in United Kingdom, in a bariatric surgical service, the prevalence of edema was more than 50%. So if you have obese patients in that kind of service, edema is very, very, very frequent. So more than 50% of those patients develop chronic edema. Next, please. There is also a study from the United States, and they looked for peripheral edema in older Americans. The age was a little bit lower, 65 years, and they had a prevalence of 19 to 20% in the years between 2000 and 2016. But again, it's about 20% in a younger age group, 65 years of age. So again, this is a very frequent finding. And if you look to the next slide, please. Can we have the next slide? Yes. So there is also the prevalence of chronic edema in health service patients in Denmark. And again, this is 39%, the prevalence. Next slide, please. We looked for edema many years ago, also in the Bonn study. This was a study where we looked for the prevalence of chronic venous disease in the adult population, 18 to 79 years. So that was a much younger population if you look to that. And edema in the last 4 weeks, in those patients, last 4 weeks was present in 14.8% of the population. And if you look to CYP3 patients, which had venous disease and edema, with pitting edema, as you see in the picture on the right, that was 13.4% of the population had a C3 disease, so venous edema disease. And stemmer sign as a sign of chronic lymphedema as a specialty was present in 1.8% with a severe stemmer sign, so toe swelling, as you see in the picture below. And if you look to the mild ones, it is 14%. So again, also if you look to those signs of lymphedema, that is very frequent in our population. Next, please. Without early interventions, chronic edema may lead to very many complications. So one of the complications is chronic inflammation. And you see cellulitis in the picture on the right, and that is one of the very frequent complications in chronic edema patients. And we have to care for those because they might be prone to go to hospital with that. There are skin changes like pigmentation, eczema, thin skin, as you see in the other picture, and you may have lymphorrhea and ulceration and cellulitis and infection. And as I said, hospital admission is the consequence of that complications in many of those patients. And keep in mind, this is a very old population. Next, please. So self-treatment of edema, of chronic edema, is very important. Of course, the first point is to reduce the risk factors like obesity with weight control and increasing mobility, because we have seen that low mobility state is a risk factor for chronic edema. So this is something which definitely has to be done by the patients in a very early stage. Of course, there should be treatment of concomitant diseases like cardiac incompetence, that is for sure. But then we have those compression treatment, for instance, which is also a kind of self-treatment for the patients. If that is not possible with medical compression stockings, as you see on the right side, that can be also done today with Velcro compression devices, which are very important for patients with low mobility, patients sitting in a wheelchair and things like that, who cannot easily reach their feet to put on compression stockings, the alternative is Velcro compression devices for those. Next slide, please. So this is a study from New Zealand. They looked for patients who had chronic edema and complications like cellulitis. And they wanted to prevent those patients from developing a new cellulitis. And they did a study with and without compression. So one group had compression stockings and the other group had no compression, just education on how to keep with chronic edema. And in the interim analysis, the 15% in the compression group, but 40% in the control group without compression developed cellulitis. And at this point, the study was stopped because of the efficacy was shown at that point, and the study could not go on. If you look to hospitalization for cellulitis in the compression group, only 7% went to hospital, but 14% in the control group without compression had to be hospitalized because of cellulitis. So you can see with a relatively easy kind of treatment, compression stockings, you can prevent a lot of complications in those patients, especially cellulitis, but that is of course also true for many other changes in the skin and skin changes and so on. Next slide, please. So in summary, chronic edema is frequent in the older population. I would say it's very frequent in the older population, but it's not only the old ones. You may have edema even with 30 years or whatsoever. So you have to look for the clinical sign, edema, not only in the feet, but also pitting edema in the preatibial region, in the lower leg. And most of the edema is in the lower leg. Early recognition, the control of the risk factors, and early treatment are key in those patients. And as you have seen in the last study, complications and especially also hospitalization can be prevented in many of those patients if you do early treatment. Thank you very much for listening.
Thank you so much. That was such an interesting talk. And, to see those results from that study about the hospital admissions, half the amount of people that were actually having just a simple treatment of compression didn't end up in a hospital stay, which has that, that effect on the patient not going into hospital, and also the cost of that hospital stay for healthcare services is huge. And by just having a simple compression treatment, it's amazing the difference it can make.